Okay, this video is going to provide an overview of the assessment of the patient with end-stage renal disease and the implications for care. So first of all, let's talk about why the kidneys fail. So there's three basic reasons. There's pre-renal, intrarenal, and post-renal. Pre-renal is that there is insufficiency in the blood flow getting to the kidney. So hypovolemic states or hypoperfusion states where the blood flow is inadequate, therefore causing what's called acute tubular necrosis or an insufficiency of the nephron to get the perfusion as it needs. So even things like congestive heart failure over time could cause pre-renal azotemia or an elevation in the waste products because the blood flow is insufficient. So pre-renal, before it gets to the kidney. Intrarenal is when the organ is assaulted directly from something. It could be something that's nephrotoxic, like nephrotoxic drugs. It could be infection of the organ, like a pyelonephritis that occurs. Last but not least, post-renal failure is when there is an injury after urine has already been formed because of some blockage that's causing backup of the urine that mechanically injures the organ itself. So it could be a renal stone in the ureter that backs up. It could even be a Foley that's not draining properly and then the urine backs up and injures the organ itself. So that is post-renal failure, very avoidable. Okay, so let's go now to the assessment of this patient and look at the normal physiology, and then when that goes wrong, the underlying pathophysiologic reason for the failure. So normally the kidney is responsible to help maintain fluid balance in the system. These hormones, ADH and aldosterone, act on the renal tubule and either change the permeability, as with ADH, reabsorbing water, or have the reabsorption of sodium with fluid following it, as with aldosterone. So when the kidney fails, what you get is a fluid volume overloaded state. It manifests in the lungs, pulmonary edema, manifests in the interstitium. The patient has lower extremity edema. So fluid volume overload is a big problem. What do we do about it? Well, all kinds of diuretics, loop diuretics, Lasix, Mumex, so whatever's going to get that fluid off. Definitely contributes to a higher blood pressure because of the excess fluid, and we'll see that that's going to be even worse because of another underlying reason for hypertension. Acid-base balance. Remember, the kidney is the other organ that helps maintain normal acid-base balance in the system, with the lungs being the other one. So with renal failure, what you have is the inability of the kidney to excrete hydrogen ions along the renal tubule, and also the inability to make that bicarb. So what you get is a metabolic acidosis. So in a metabolic acidosis, what you have is an acidic environment which is driving down that buffer, that bicarb. So you get a pH that's low, you get a bicarb that's low, and what's the system's response? What's the compensation that's going to occur is we're going to increase the rate and depth of ventilation to blow off our respiratory acids. So what you also get is a CO2 that's low. So in this compensated metabolic acidosis, you get pH low, bicarb low, and the CO2 that's also low. Just a quick review. Also, the kidney is responsible to secrete erythropoietin hormone, and we don't think of the kidney as an endocrine organ, but it really does release quite a few hormones. So this erythropoietin acts upon the bone marrow so that red blood cells are produced. So when the kidney fails, what you get is pretty severe anemia. So we're always struggling to keep those hemoglobins above 7. Erythropoietin injections is going to be an exogenous form of that hormone to help prompt the bone marrow to produce red blood cells because the kidney is not secreting that hormone. Maintenance of electrolyte balance. Okay, let's talk about potassium. So normally the kidney is responsible to maintain normal potassium levels. So in renal failure, that potassium level does go up. And remember, potassium, when it's not within normal range, you get some pretty severe cardiac repercussions. So with hyperkalemia, you're going to get blocks and Brady's to occur. A peaked T wave, remember, is something that you could see on the EKG. So certainly when it gets to dangerous levels, we want to do hemodialysis, but there's also a list of other things that we can review after to reduce hyperkalemia or dangerously high potassium levels. Sodium is also going to be an electrolyte to look at. Elevated sodium levels, hypernatremia, not quite as dangerous in this circumstance as the potassium is. Phosphorus, hyperphosphatemia, and when you have an elevated phosphorus level, it drives down the calcium level. So the patient's going to get hyperphosphatemia, hypocalcemia. So we give phosphate binders for that. Something, for example, Phoslo and Renagel will bind to phosphorus and bring it down. So hypocalcemia is going to be an issue, and the phosphate binders are going to help address that. But you're also going to have a decreased calcium level because of the kidney's inability to secrete this hormone 2,3-DPG, which is the active form of vitamin D. So without vitamin D, we're not absorbing our calcium. So another approach to addressing this hypocalcemia is to give the active form of vitamin D. Calcitrol is an example of that. Okay, so let's look at another big problem with these renal failure patients, and that is hypertension. So their blood pressures are so severely elevated. Remember, the kidney is responsible to secrete that hormone renin, which is converted to angiotensin 1, which is then converted to angiotensin 2 because of a converting enzyme. Angiotensin 2 is the most potent vasoconstrictor in the body, raises that blood pressure. In addition, angiotensin 2 causes the release of aldosterone from the adrenal cortex, which is also going to contribute to a hearty intravascular volume, which is also going to increase blood pressure. So this hypertensive state is really difficult to manage in these patients. We try every level of antihypertensive drug, the thiazide, diuretics, calcium channel blockers, beta blockers, alpha blockers, to try to get that blood pressure in control. So of course it stands to reason that congestive heart failure, cardiac failure is a sequelae when this has been long-standing. So eventually with end-stage renal failure patients, they're going to suffer from cardiomyopathy and cardiac failure. Elimination of the waste products of metabolism like blood urea nitrogen and creatinine. So remember, blood urea nitrogen is the one that could elevate but really not signify necessarily renal impairment, because other things elevate the BUN. States like dehydration or just an excessive protein intake could cause a jump in the BUN with the creatinine still being maintained, because creatinine is the byproduct of skeletal muscle catabolism. So that's not going to vary at all. So creatinine is normally a very stable number, and that's only going to elevate if there is an insufficiency of the renal system to excrete it. So what happens when the kidney fails and these waste products of BUN and creatinine begin to elevate is that every organ system is going to manifest something. From head to toe, we're going to have cognition that's impaired. Patient is going to be confused, maybe lethargic because of these waste products affecting their ability to think. The GI system, patient's going to be just nauseous because blood flow to the stomach is going to have these waste products in it. It's like garbage in the system circulating everywhere. In addition, it's going to be excreted through the skin. Remember, our skin is the largest excretory organ, and that waste is going to come through the skin and cause this pruritus. Patients are going to be so uncomfortable just scratching and scratching. In addition, over time, they're going to form what's called a uremic frost on their eyebrows. So you're going to notice that possibly, and the darker the skin, the easier it is to see the frost that begins to appear. In addition, these waste products cause an irritation and an inflammation in the sac around the heart and cause a dry pericarditis. It's not an infectious state, but it is an inflamed state and to an already kind of stressed heart. In addition, this causes a decrease in immune function because these waste products are going to impair normal immune function. B cell immunity and T cell immunity is going to be impaired. In addition, these waste products are going to damage the platelet. The platelet, remember, is that blood component that is pretty fragile and easily damaged. So if the patient's on hemodialysis, it will damage the platelet by going through the machine. In addition, just having these waste products in the system will also damage the platelets. So look out for a patient who's thrombocytopenic. In addition, remember, being hypocalcemic, the system is going to draw the calcium from somewhere. So the patient's also going to be suffering from osteoporosis over time because you're going to try to, draw calcium from the bones demineralize. These patients have very brittle bones. So if they fall, their cognition is impaired. So safety is a big issue, and then they could break a bone. In addition, if they're anemic, so therefore they're not going to be strong, and if they've, a higher risk for fall because of that, so they're going to be breaking their bones or certainly have a high risk to break their bones. Let's talk about diet teaching. Well, certainly they may be on fluid restriction, decreased potassium diet. So you have to know what foods are high in potassium, things like citrus, things like melons and cantaloupe. So a lot of these summer fruits and vegetables are high in potassium. Don't confuse potassium with vitamin K, which happens a lot. So yes, vitamin K is green leafy vegetables, but potassium foods are going to be more like the melons and the citrus and the summer fruits. Foods that are high in sodium need to be avoided because that's going to just contribute to fluid volume overload. So canned foods, processed foods, junk foods like pretzels are going to be really high in sodium, and they're going to contribute to the fluid overload, the stress on the heart even more. Low protein, because remember, protein, when it's metabolized, forms the waste product of blood urea nitrogen. So that's going to be more for the kidney to excrete, and then it's going to contribute to this uremic state even more and stress the organs.